So whenever you get a picture like this, remember this is a selective angiogram of whatever artery you decide to call it. So selective DSA, spot image, or angiogram selective. So this is selective angiogram. You can see a catheter has been placed into this artery and contrast has been given to delineate only this artery and nothing else. You can see some reflux here that goes back into the aorta. So this is normal. This is artifact. I wouldn't worry about this. However, this is not the IMA. This is the SMA. And why? If you think about, you can see the vertebral bodies back here. You can see 1, 2, 3, all the way up to maybe L2, and you can see the renal calyx outline here. So you would not expect the IMA to be this high up. So this is the SMA. So when in doubt, you always have some kind of bony reference. You might have the diaphragm higher up here. So just remember at which level do these arteries come off of. So this is
actually direction is I have seen this SM is most of the time on the right side and IMM is most of the time on the left side. That's why
you are right, but then angiograms can be done in different projections. So I wouldn't completely rely on that fact. But remember, where is this? Remember, where is this artery coming off of? This is coming off too high to be the IMA, right? The IMA you would expect at the lower down, not all the way up here. So this is an SMA selective angiogram. Okay, so as we go through it, you didn't see anything there. As we go through it, what do you see? So I'm going to go back to the first image, 2, 3.
Yes, sir.
What do you see? So this is a selective SMA angiogram. I'm going to show you further images of this run. So this is the first image, second, and third. Any comments?
Yes, sir. Last one is likely after management, embolization, then because the blush of contrast is not seen and only outlining of the bowel is noted.
Okay, I'll stop here. So focus on this area, okay? So remember, as the pictures I'm showing you are the contrast traveling, or you could say blood traveling through these vessels. So this is active arterial bleeding.
Bleeding, yes.
This is what active arterial bleeding is. Embolization hasn't been done yet. This is active arterial bleeding. This is what arterial bleeding looks like on an angiogram. There are many ways that bleeding manifests on an angiogram, but let's just stick to this is active contrast extravasation on an angiogram. Okay? So remember this picture, all right? You can see that the contrast is not in some kind of anatomical vessel plane. This is certainly not bowel. You can see the bowel gas outline here, and you really don't see anything that, you could say constant. So this is active extravasation of contrast. Okay, and that's fine. So just to kind of explain learning points here, identify the artery at what level it is correctly. And then all I wanted you to pick up is and show you, you may not have seen this before, and that's why you're here, is to show you what active contrast extravasation looks like. The same patient, so this is more magnified view. This was the source of the bleeding, and some of those coils that I showed you earlier were placed. Okay, any questions, doctor, with this study?
Only I want to know the branch which have this blush bleed. Which vessel is this of SMA?
This is probably one of the ileocolic branches.
Okay.
Probably the right colic artery bleed here. Okay,
thank you so much.
You're welcome. Okay. Has chronic liver disease with ascites.
Yes.
Yes?
Yes.
Okay. And they also have, okay, so with that knowledge, and if I told you the spleen was enlarged, what is this? What are these?
So these are varices, splenic varices.
Excellent. Okay. So now we've identified these are varices. Let's come to your friend over here. Have you ever seen this before? So this patient has varices. Okay?
Okay.
CT scan has been done.
Okay.
So if they have varices, and if they have ascites, and if they have chronic liver disease, and an enlarged spleen, what condition do they have? What is this? This is called what? Complication of cirrhosis. What complication of cirrhosis? All of these come under one complication of cirrhosis.
Okay. So bending of varices.
No. So this patient has portal hypertension, right?
Okay.
With all the features that you and I have found, so the ascites, the varices, the splenomegaly, okay?
Okay.
This has got, so let's just stick on, this structure is related to the varices. What is this? Okay, so this is a gastric balloon, okay? So this patient had a Singstocken-Blakemore tube inserted and was transferred from another hospital to our hospital. I was doing my fellowship during this time, and the treatment of somebody with bleeding varices, once they've failed endoscopic treatment, is inevitably to have a TIPS procedure, okay? So this patient is in the midst of having a TIPS procedure through the transjugular approach. This is the hepatic vein. Access has been gained into the portal vein. You can see a huge varix over here. You can see the outline of the balloon that I showed you earlier. Okay, yes. Your interrogation is stopped. I'm just now going to teach you, so relax now. So a tip stent has been deployed. You can still see the gastric balloon, or Singstocken-Blakemore tube. If you don't remember that, the gastric balloon. The gastric balloon is inflated into the stomach and also in the esophagus if you use the esophageal balloon to tamponade, to stop the bleeding varices. And that can stay up for up to about 24 hours. After that, you need to do something to stop the bleeding, because then you can cause ischemic necrosis of the esophagus and of the stomach. So a tip stent was put in. I'm not going to go into why a tip stent is inserted, because remember, I'm talking about embolic agents. You can still see, despite a tip stent, you can see these varices. And as I go through this image, selective venogram of this varix shows active contrast extravasation. So this varix is still bleeding. So this is a gastric balloon. You may be shown a plain film of this, so remember that. And here's the glue that has been endoscopically injected in an unsuccessful attempt to stop the bleeding. And the reason why I'm showing you all of this is these plugs were then deployed to stop the bleeding. Okay. And then big plugs were then put in to close that varix, because we want to divert flow away from these varices into the tip stent. And this is why I'm showing you this, is to show you these are appearances of vascular plugs. So you might find a plain film with a picture of this appearance. These are vascular plugs, or you can say embolic material. You know, for in an exam, if you don't remember plugs, coils, whatever, say embolic material. And why is an embolic material put in? To stop bleeding. That's all I wanted you to know from this little spiel. Trauma protocol that is used in major trauma centers. I can't remember why I was showing you this. Oh yes, okay. So interventional radiologists. Now this is just to show you what is arterial extravasation, how to differentiate between the two. Arterial extravasation is the only reason why I will get out of bed and do something about this patient. And what is arterial extravasation on a CT? This occurs in the clinical context of somebody who is verging towards becoming hemodynamically unstable. They are actively, continuously bleeding. So what does this look like? They hopefully had an arterial phase and a venous phase. They have a focus of a pool of contrast material wherever they're bleeding from. And on the venous or delayed phase, this expands, it becomes bigger. It is of a higher attenuation than the aorta on the venous phase. So this is the feature of active arterial bleeding. On the arterial phase, you'll see a focus of bleeding, and on the venous phase, it changes its shape, gets bigger, and the density is higher than the aorta, because we're now in the venous phase of the CT. Now then, if you see areas of high attenuation on the venous and delayed phase, and there is no correspondent enhancement on the arterial phase, it is not active arterial bleeding. It is either fractured bone or venous hemorrhage. The patient had radiofrequency ablation for an HCC.
Okay. So sorry, radiofrequency ablation for?
For a hepatoma or a hepatocellular carcinoma.
Okay, HCC. Okay.
I'm going to show you two images. This is one, and this is the other one. Okay, so I'm going to show you this first.
Okay. Sir, I'm provided with a single axial CT abdomen image with contrast, and I can appreciate that there is evidence of ascites, and at the tip of a metallic tip is noted within the stomach, and there is significant soft tissue thickening around the right anterior and lateral abdominal wall with evidence of ascites, and few calcific foci, and straining in the subcutaneous tissue is also noted, could be due to post effects of the radiofrequency ablation. And I cannot appreciate any lesion within the liver, which is hyper-enhancing. And the visualized part of the spleen appears to be normal. However, few hyper-enhancing foci are noted within the region of the stomach.
Okay. Oh, so this is a CT abdomen pelvis. Can you elaborate more on what phase is this? What phase is
So this is the early arterial
okay.
phase, because the contrast is opacifying the abdominal aorta.
Okay, I'm going to show you a venous phase CT, and I want you to focus on this area. So this is the arterial phase CT. This is the venous phase CT. Now,
okay.
I think if I remind you the history, the patient had radiofrequency ablation, which is a percutaneous. Yeah. So basically, an 18 or a 17 gauge needle has been inserted percutaneously into the liver to ablate a lesion, and then was removed. So given that in mind, what are your findings? What do you see here? So this is the arterial phase, and forget about everything else. I want you to focus here and here.
Okay. So, so I'm pertinent with the history of the radiofrequency ablation and the insertion of the needle. There is a linear hyper attenuating focus, which was in the arterial phase, and it has changed its shape, and it has become more denser than the aorta in the venous phase.
Okay. So,
yes, sir, I can appreciate the difference between the density of this high attenuation area in the abdominal wall and the aorta. So,
what do you think this is?
It can be any arterial extravasation or bleed.
Okay, all right. So, are you still calling this ascites, or would you like to call this something else?
No, sir. I will ask. No, sir. This is hyper attenuating ascites. It can be a hematoma pericapsular hemorrhage.
Because you can see some ascites here, and the density, as you can appreciate, is far different here.
Sir.
So this is what then? So this patient has got active arterial bleeding. Yes.
Yeah.
From a radiofrequency ablation. Okay.
Yes, sir.
Good. All right. So then interventional radiology was woken up, and you can see this hematoma that squashed the liver. This is the bleed here. And the patient's not bleeding from inside the liver. They're bleeding somewhere else. They're bleeding in the abdominal wall.
Within the abdominal wall.
Yes. So where is this catheter, and what is it pacified?
Okay, so this catheter, this is a selective angiogram image, and I think that it has opacified some of the branch of the celiac trunk.
Where are we at the moment? Now this is a
so
DSA.
We are superficial. Yes, sir.
Where are we? Okay, what is this? What are these?
Sir, I can appreciate these are the bilateral renal arteries and abdominal aorta.
Okay. What is this? What is this structure that divides into two? It has C-shaped rings. Where are we? Okay. So this is a thorax.
Okay, sir. We are in the thorax. We are in the thorax.
Well, yes, we are now. Okay, so do you want to change your answer?
Yeah, sir. So I think this is the subclavian artery, I think. Or
which one?
Right.
Which one?
Right,
yes.
Subclavian artery.
Good. Yes. Excellent. So this is a selective right subclavian artery angiogram.
Yes, sir.
Okay.
Yes, sir.
So tell me what this branch is.
So vertebral artery.
And this one?
Sir,
gave it away. What is this branch?
Internal memory artery, costophrenic, or internal memory.
Yes. Internal memory artery. Okay.
Memory artery.
So this is a selective. So remember, on a DSA study, okay, have a look at the non-vascular landmarks that may help you. You can see the trachea here. You can see the bifurcation in the left and right main bronchus. So almost certainly we're not in celiac artery territory. Okay. And the bleed is in the anterior abdominal wall. So the celiac artery does not supply the anterior abdominal wall.
Yes, sir, I
So
know
now
that,
you can
but my
see the
eyes
trachea,
were
you can see the
watching these as abdomen because we just viewed the abdomen, that how our brain works in the Viva.
Fair enough. Fair enough. That's fine. So what you need to do is kind of step back and have a look at the film. Don't focus on the arteries. See what's around it. This is how we identify as interventional radiology, how we identify. You can see the lungs. You can just about see some ribs here, but this trachea kind of gives it away. Okay, so this is the bleeder. So it was bleeding from the internal mammary artery. And here's active bleeding. And then this is embolized with a couple of coils. And just to finish a picture, we then did an angiogram of the inferior epigastric artery. There's no evidence of.
Okay, so I'm provided with chest X-ray, frontal projection taken in a semi-sitting position. I can see that I'm looking. I can see that there is a homogeneous opacification seen involving the left middle and the lower zones, which is partially obscuring the left heart border. And however, the left hemidiaphragm is intact. I'm looking at the costophrenic angles, they are intact. The left upper zone and the right lung appear unremarkable. So I'm thinking of this, and I can see the faint visualization of the pulmonary vascularity behind this mass, behind this area. So this appears to me as a mediastinal mass. Okay. I'm trying to visualize the location of this mass.
Okay.
The aortic arch is unremarkable, and I'm unable to trace the descending aorta through it. So this can be either an anterior or the posterior mediastinal mass.
Could it be anywhere else? Apart from the mediastinum?
Within the lung, pairing within the lung?
Do you think it's within the lungs?
I don't think.
Well, okay, so you've talked about mediastinum, lungs, where else can it be?
It could be, it doesn't look into the pleura. The other thing that left is pleura. I don't think it's in the pleura because it's not making an obtuse angle. Its epicenter is within the lung, within the thorax, hemithorax. So I don't think it's within the pleura.
Okay, I'm going to stop you here. Not an easy one. It's not classical pleural-based mass. So this is indeed a pleural-based mass.
Okay.
And this is a calcified fibrous tumor of the pleura. But again, the final diagnosis is not important. I like your thought process that, okay, if it's not in the lung, is it the mediastinum? Could it be somewhere else? And in real world, you would ask for some previous films. You might have been given some relevant history. You might have been given a lateral chest X-ray to look at. So again, you know, it's your thought process that I wanted to trigger off rather than for you to get this. This is obviously not a diagnosis made solely based on that X-ray. So remember the chest wall as well for your masses.
Yeah, but its epicenter wasn't in the pleura need, so I was thinking of that it can't be pleural based mass, so that's why I was with.
Sure. But then you know, look at where it's situated. And I'll show you another one later on, and I can understand what you're saying. And anyway, I'm not an expert at chest radiology, so the less I say, the better.
Okay, I'm provided with frontal chest X-ray projection of a supine patient. I can see that the both. I'm trying to look at the lungs. They appear grossly unremarkable. I'm looking at the mediastinum. I'm looking at the trachea and the heart appear grossly unremarkable. And can see that the both hyla appears prominent. And I'm trying to see the vessels through them. The vessels, the pulmonary arteries appear unremarkable. However, there is a prominence of the pulmonary conus on the left side. Left pulmonary conus, but the pulmonary conus is prominent. So based on this, I'm thinking of this as a prominent pulmonary arteries on both sides.
Okay. Otherwise called what? Yes.
Pulmonary arterial hypertension. But I cannot see that there's pruning of the vascularity isn't visible, or either I'm not able to figure that out.
Okay. Ignore the left hemithorax. Just focus on this. So this is, what did you call this? Prominent pulmonary arteries, right?
Yeah.
What prominent pulmonary artery means an enlarged pulmonary artery, right?
Yeah.
So what's an enlarged pulmonary artery called?
Enlarged?
Begins with an A.
Sorry?
This is a prominent or an enlarged pulmonary artery. This is an enlarged pulmonary artery. Right?
Enlarged pulmonary artery, okay. Yeah, it is an enlarged pulmonary artery.
What's another name for an enlarged artery? I told you at the very beginning. Aneurysm.
Okay, pulmonary artery aneurysm, okay.
These are bilateral pulmonary artery aneurysms. Okay, and here's the CT scan. Now I just want you to concentrate on the CT. So you see multiple pulmonary artery aneurysms here.
Aneurysm, okay.
Okay, what conditions do you see pulmonary artery aneurysms in?
Pulmonary artery aneurysms, if I would like to take the age of the patient, and if he's a young patient, we do see that in any syndromic diseases, or we see that in connective tissue disorders.
Such as
Marfan and Ehlers-Danlos syndromes, or we have that association with Behçet disease, Behçet syndromes, pulmonary artery aneurysm. I would like to take the history of any ulcerations in the skins to confirm that.
So you can see here some ground glass change here in the lungs and bilateral pulmonary artery aneurysms, and this indeed was Behçet syndrome.
This is chest X-ray frontal projection of skeletally mature patient. There is a soft tissue radio opacity projecting over the right cardiophrenic angle. It is, however, not obscuring the right pericardic border and the right medial aspect of the hemidiaphragm. It is not showing any calcification or cavitation. Visualized part of the bilateral lung parenchyma are grossly normal with no evidence of airspace opacification or collapse. Bilateral hilar regions are normal in size, and there is no mediastinal shift. CP angles are also unremarkable, and I'm looking at the soft tissues and bones, and these are also normal. So I'm thinking of a mediastinal mass. As it is not silhouetting the pericardic border, so it's likely in the middle mediastinum or the posterior mediastinum. For that, I will look at the lateral chest X-ray.
Okay, excellent. So if it's a posterior mediastinal mass, what is your differential diagnosis? I know I'm talking to chest radiologists. What's your differential diagnosis there?
Okay. I'm thinking of neurogenic tumors like schwannoma, neurofibroma, paragangliomas, any bronchogenic cyst or foregut duplication cyst, or can be lymphadenopathy.
Okay, all right, excellent. So X-ray or looking at a different view. So always remember when you're showing an X-ray and you've got a differential diagnosis, you want to take this further. What would you do in the real world if you're reporting this? You would look at previous chest X-rays. So this, you might find one from 10 years ago and it's still there, or this is something recent. So your differential diagnosis will change according to the chronicity of this finding. And obviously you would look at any you'd ask for any cross-sectional imaging. So excellent. So this is the lesion. Okay, so this is the arterial phase CT. What is it?
Okay, this is a soft tissue density lesion, and its center is well opacified. It is taking contrast, and so it can be aneurysm of. I will look through the other images to look for the continuity with the main vessel, but the way it is opacifying, it looks more like an aneurysm.
Excellent. So this is an aneurysm of the T10 artery, and this is the T10 artery aneurysm, and then this is embolized. So you can see on the final image, you don't see this aneurysm opacified anymore. So this aneurysm was embolized. Excellent. You're not going to be, this is really, really fine print, but what I really liked is your technique and how you very quickly ascertain this is a middle or posterior mediastinal mass. Your differential diagnosis for your posterior mediastinal masses was perfect. And as soon as I showed you the CT scan on the arterial phase, so always remember the phase of the CT, you quickly cotton on that this is some form of aneurysm. And that's more than that is expected from you.
I am provided with exercises, CT scan, thorax of mediastinal window. There is a bilateral pleural effusion. I can see, and there is also a hypodense area which is surrounding the descending aorta, thoracic aorta, up to the visualized slices up to the descending abdominal aorta. This is with the bilateral atelectic lung also noted.
Get the lungs, ignore the lungs. Don't worry about the lungs, but you're doing very well.
Aorta is also, this is a arterialized showing the contrast of the visualized aorta. There is no any, I can see the peripheral outlining of the aorta clearly. There is no defect is seen, but there is a surrounding hypodense area is noted up to the visualized thoracic and abdominal aorta. No up to the superior mesenteric, celiac artery. This hypodense area is surrounding the more towards the right side, and so if there is any intervention is done or any trauma history, there will be a
okay. All right. You've done very well. You've done, I'll stop you there. Before I go on, can you tell me what this artery is?
Subclavian.
Which one?
Left side.
Okay. What is this? Let's assume conventional aortic arch anatomy. What is this one?
Here.
This one? Okay, what about this one then? So left subclavian artery, what's this one? Or this one? Pick, you take your pick. Which one do you want to tell me, this one or this one? Okay.
Subclavian wing.
No. Okay, all right, so this is the left subclavian artery. This is the left common carotid artery, and this is the brachiocephalic or the innominate artery. So this is the conventional aortic arch anatomy. And the reason why I'm showing you this is that I don't know. You might be viewing it on a device that is difficult to appreciate. But if you just focus on the aorta, there is a constant crescenteric density, almost circumferential, surrounding or crescenteric, almost surrounding one side of the aorta, and it is constant in its appearance. And it starts distal to the left subclavian artery. And as you go down, you can see that this is not hypodense, you would say this is hyperdense. So crescenteric hyperdense thickening of one side of the aortic wall. This pleural effusion, if you look, this is a pleural effusion. Is there a difference in density between this and this?
Sir, this density is equals to this peri-aortic density.
So this is more hyperdense compared to this. So this is not a standard pleural effusion. So this has something to do with this pathology. Do you know what this is? Do you know the answer?
Mentoma? Is there any intervention is done or any trauma history? So would be
okay. All right. So there's no history of intervention, and there's no history of trauma. So this is a hematoma of the aorta. And this patient came with chest pain. Do you know the name of this condition? And while you're here, tell me what these are. You didn't tell me about these. So imagine if you had this in the stomach, right? So imagine if this is the wall of the stomach and you had one of these. What do you call these in the stomach? These are, so imagine if this was the stomach, what is this? This is an ulcer, right?
Sorry, sir, I can't.
So imagine if this was the stomach. You see these finger-like projections coming out into the wall. So these are ulcer-like projections. So these are ulcers. These are penetrating ulcers of the aorta. And what I've shown you, hyperdense crescenteric rim around the aorta that starts at distal to the left subclavian artery. What I'm showing you is, and I'm going to talk about this later, this is a type B intramural hematoma with an ulcer-like projection. So the type B IMA.